Thank you, Mr. Speaker. The face of medicine has changed. This face is changing very rapidly. And it is up to us, each and every one of us here in this assembly, to address these changes and try to keep pace with what changes occur in the practice of medicine. The good old Norman Rockwell painting that I'm sure a lot of us are very familiar with, where you have a very authoritative, a very dictatorial doctor talking down, talking to, but actually talking down to the mother of the child, instructing her what to do. That's a painting we're all very familiar with, and many of us even probably have it in our homes. I definitely do. Things have changed. Healthcare has changed, and it is no longer a one-person show. It is a team effort, and together, all of us try to do the best that we can to serve our patients, to serve our constituents right here in the Assembly, so that healthcare delivery is more effective and healthcare delivery is more cost-effective as well. That is our goal. That is our common goal. With the passage of the Affordable Care Act, we know we have challenges that we have to face. And we here in Connecticut can definitely be proud that we were one step ahead. We were very proactive in what needed to be done, and are the envy of the nation for how prepared we are when the Affordable Care Act, of course, as all its delays, is finally implemented for one and all. So we are aware of the changing landscape in medicine, a paradigm shift from a single person calling all the shots, calling all the orders, to a team effort comprising of the MD, the APRN, the PA, and of course, a whole long list of other healthcare providers as well. That is how medicine is delivered today. And of course, we don't know this changing face in the decade or the decades to come. So with this changing landscape that we all have to face with, we realized that this collaborative agreement that exists between the physician and the APRN, a very loose collaborative agreement passed back in 1989, if I remember correctly. That agreement, that collaborative agreement, is not a tight one. It is very open. It is very loose-ended. We heard that, I heard that for the first time in the public hearings last year as to how loose some of these arrangements are. And we heard it again this year, a repeat performance of the concerns that the APRNs had with regards to their collaborative agreement. Is the present collaborative agreement perfect? Is it what it should be? The answer is absolutely no. But two wrongs do not make it right. And that is my concern on Senate Bill 36 here today. Yes, we do not have a collaborative agreement that is effective. So do we go the other extreme, 180 degrees, and then say we do not need the collaborative agreement at all? I think for us to look at this bill, to look at the changing face of medicine, to look at where we are and what our requirements are, is to look at this collaboration, to make it meaningful, to make it work. Let us not go from one end of the spectrum to the other. That is definitely not the right way to go. We are all here to do the right thing. I know we will all do the right thing. This is not a Republican issue. This is not an issue for the Democrats. This is not about MDs. This is not about APRNs. They are not what the center stage is all about. The center stage is patient care. The center stage is access. And the center stage is to make sure that these patients are treated in an appropriate way, and we do not end up in different tiers of care, a first level care and a second level care, which is what my concern is if this bill were to pass. So this bill is a good start, is a step in the right direction. That collaboration needs to be revisited, collaboration needs to be looked at and modified so that we have an effective way that we can have this relationship between the MD and the APRN. Eliminating the collaboration is not the answer.